Invitation to speak. So I put this out to be a good PI, but actually it's about PI-CI relationship. So Jared said to me, just put up a few slides, I'll put up a few slides and we'll have a chat. I've got my slides. So I think I just want to start, I think Jared you'll come in one year, and I just want to sort of talk about I guess my journey as a PI. So I was appointed in 2010 and I work in Chester, so it sits just on the border actually to Wales. When I started, we were not a research active centre or unit. It wasn't something we reviewed about, and I think, chatting with people last night, this is really about research is not, it's for everyone, it's not the ivory towers, and we had a kind of mission statement really that we wanted to be a research active unit. And that's really when I first met Jared with a heart study, and that was 2012, Jared, I think, wasn't it? And that was our first time that we'd ever got into clinical research. And at that time, I'd never recruited a patient, our unit had never recruited patients, and I guess part of today is just to talk about how we got from there, where today, in the time I've sat here, we've recruited 3 or 4 patients to clinical trials, because the unit now just runs research as part of everyday practice. It's integral. So I don't need to be there. I can act as PI, but the trainees, the physicians associates, the nurses, pretty much every patient that comes in gets recruited into a trial. So I guess really it's to talk from a PI perspective of how we do that, and then perhaps for Jared and I to talk about how as a PI and a CI you work together. What does a PI need from a CI, and what does a CI need from the PI to make your trial effective? We've talked about how you set up a trial, how you fund it, but ultimately on the ground, how do you get that recruitment? So I kind of always begin a lot of these talks about, and I know I'm sort of preaching to the converted, but I think it's always worth refreshing why we should be taking part in research, and I kind of talk about it because a lot of this is about hearts and minds. How do you convince the people in your unit or in your department? Because, as I've just said, you can't do it all by yourself. So you have to get everybody on board with research. And so it's trying to sell that vision and why it's important. And of course, ultimately, it's about patients. And we know, and I know I've seen in your documents, centres that are research active, the outcomes are better. And so ultimately, it's about patient outcomes, it's about patient experience. Pretty much most of our patients who take part in research really enjoy the experience and actually feel as though they've got ownership and involvement in their care. So it is ultimately about patients. For me as an individual, it's been an amazing journey, starting from 2012 when we started recruiting to clinical trials to today, where I've been involved in so many studies, both as a PI and as a CI. So it's made my career hugely rewarding, and it's enriched it, not just from a surgical perspective. We're going to talk about trainees, because I think part of the success we've had locally in Chester is about involving all our trainees, because that's the next generation of researchers, and we'll touch about how we've started back in 2010 having trainees involved, and then the associate PI scheme that's come along that's really made that much easier, and it makes sure that the trainees get rewarded for their involvement in research. And there's been definite benefits to our unit and to our trust. We exist like many small hospitals on minimal staffing rotas. We have gaps in the trainee rotas, so research registrars have been able to plug those gaps for us. So there's been real benefits. And again, going back to the trust, the patient outcomes are better, and therefore the trust outcomes are better. And we know that CQC and our regulators now look at involvement in research. So there's all those variety of benefits. However, and I've just put this, I don't know if people have seen this letter that was written to the Health Secretary. This was just looking at the state of NHS clinical research and the problems it faces. So there's still a lot to do to try and get everyone involved in clinical research. So I guess the main sort of part of this talk is how do we do it, and it's a team approach, it's a team sport. Everybody has to be involved in research, and we really try to develop this ethos that research was pretty much part of our core business, everything we do. And it really centred for us, and certainly in the terms of cancer, around our MDT, because we have a cancer MDT which stages the disease. We run audits, and the extra position for us was what trial can the patient go into. So it really became just a standard of care that it was accepted that every patient would go into a trial. So our Monday morning MDT started off as an MDT followed by a research MDT. And we had that as a policy. We spread the workload and we made sure that everyone had their GCP training. We involved everyone. Research wasn't just for the consultants, it was stoma nurses, trainees. So I've had stoma nurses run the CIPHER study, I've had the Physicians Associates run Rossini and some of the other sort of wound infection studies, so everybody got involved. As I said, when we started, the Associate PI scheme wasn't something that existed, but we've now got that, so all our trainees get sort of appointed a trial to run. So at the moment we have about a portfolio of 6 to 8 studies running in the department. So each person gets allocated a study. There's a consultant PI and then there's a trainee associate PI. And I think in terms of how you set up your research unit, it's like anything else in life. You start simple. You start with some easy studies, and you don't have to dive straight into a randomised interventional drug trial. Start off with some prospective studies. And again, I know Tom, I'm sure, will talk about prospective observational studies, red cap studies, easy observational studies, so they're low-hanging fruit. You can get big numbers in. It gets people to understand research methodology and how you get involved. And it kind of, hopefully, gets the bug for the team to get involved in research. You need to get what I call sort of a balanced portfolio as you grow and bring new studies in, so you sort of balance the number of interventional studies. There are some studies that are quite hard to recruit, and of course your R&D managers will look at it and say, well, you've only got 2 or 3 patients because they're difficult, so you kind of have a balanced portfolio of easy to recruit studies with the more complex ones. You have to have that team approach, and you have to be a really sort of proactive and enthusiastic PI. You have to sort of get out there. And again, part of the trade-off of coming to events like this is that's where you find out the next trials. And ultimately, if you get more and more involved, you actually develop and lead those trials. So it's this sort of iterative process. The more you do, the more you get out of it. Definitely as a clinician, you have to get to know your R&D department. I've got a really good relationship with my research nurse and research department, so they know what I'm doing, they know what I want to do next, and once you can establish that you can deliver on those studies, they know there's no problem with you opening the next one. So you have to sort of, but it takes time, and it's taken me 10 years to get to that state now that I know if I ask them that I can open the next study, they'll do it. Spreading the workload, I think, is really important, and again, I'm going to go back to the heart study because it's the way it worked really well, and it's the way we got the big numbers. And again, it goes back to patient care. So with the heart study, which was a wound closure for a laparotomy wound, we had a closure team. So the primary surgeons would do the cancer surgery, and then 2 or 3 of us that were trained in doing the heart technique would then replace the operating team. So if you just think about that from a patient perspective, you know, you get a whole separate 2 consultant or consultant training team just closing your abdomen. So there's the benefits of being involved in research, and it meant we were able to get big numbers. So it really is about sort of spreading that workload, and we've adopted that same approach to further studies. So you can't expect everyone to do everything. So again, it's about sharing it around as a team. I think the other thing that's really important as a clinician is you mustn't forget what happens after recruitment, because of course we look at the numbers, but ultimately the numbers are only one thing. If you don't get that data, if you don't get the follow-up data, then the trial, that's not going to help. And so from a CI's perspective, Jared doesn't want me just to recruit patients but then not get any of the follow-up data. You need to get that follow-up data. So we did a few things. We set up a research clinic. So every single patient that was in a trial could go to the clinic with a research nurse. It didn't need trust resources because all the data is within the sort of trust within the research CRFs. So different trials would all go on a certain afternoon. So you could have 3 or 4 different trial patient studies all going into an afternoon, just into a room, and all the sort of follow-up data could be done there. If there's any clinical review need, people are around. So that was really effective. I think if you're going to invest in support staff, data support managers are really important, just particularly in terms of uploading data, checking the CRFs. So actually you don't always need a research nurse. Actually, if you're going to invest in anything, a data support manager would be really good. I've got WhatsApp on there, and that's the other thing that we use really well. I know everyone's probably sick of WhatsApp groups, isn't it? There's a sort of WhatsApp group for everything, and we have a WhatsApp trials group, but it's a really good way of getting the information around the trust. So if we are, for example, today where we're randomising for Rossini, the study numbers will come up, People make sure they get the 7-day wound checks, and we have, you know, all the house officers, all the SHOs, all the registrars, plus research nurses, plus stomachs, all on the research WhatsApp group, so we don't lose any patients. We make sure all the checks get done, and it works really well. So just to sort of finish off my section, really, I think as you get bigger, that's the other big problem. Success breeds success, and it's great because more and more people then come to you because you can deliver on the studies. So you do have to sort of be a little bit balanced and a bit careful. You do have to review your portfolio regularly, make sure you're not overcommitting. You do need to try and reduce conflicted studies. So for example, if there's lots of wound infection studies, obviously you only want to keep 1 or 2 going at the most, otherwise you're going to start to not affect your numbers. So you've just got to make sure you don't conflict. Every time the junior doctors rotate, you have to be proactive and sort of update them. And actually now, our junior doctors update themselves, or our physicians associates, they take my role on and just make sure that the next group of doctors that are coming along are ready to go. So that works really well. You definitely don't want to take on too much. And people often ask me about how you go through the whole process with your patients, because obviously when a patient comes to clinic with a cancer diagnosis, it's very much about the cancer diagnosis. As opposed to the research, and you've got to balance that. So typically I will, we'll do most of the discussion around their clinical treatment, consent for their surgery. They'll get the information sheets to say, and I'll introduce the concept of the trials to them. And it's amazing, and I'm still amazed now, how altruistic patients are. You'll say to them, ultimately you're doing this for the goodness of future patients, and amazingly still, patients with cancer who are still waiting treatment say, absolutely, I know this is not for me, I know this is for the next patient along. And it still amazes me every day that patients will still do that. Where we give them the information, and often for us, the way we're working now, they'll get 2 or 3 studies. They'll get a translational biosample study, they'll get a wound infection study, they'll get an ECG study, so they'll get 2 or 3 bits of information all at the same time. So you do have to be careful not to overwhelm them too much. You definitely have to support your research nurses. I'm sure there's lots of research nurses out in the room, but you have to support them as a PI as you get busier, so you can't just put things off. So when they come to you saying, look at these CRF signing me, you have to be really proactive and help them, because if you don't, then things will start to slow down. So you really spend the time and put it aside. And ultimately, I think for me, move on from a PI, get involved in trial management, get involved in the things that Dean and Susan were talking about, trial management groups, data monitoring committees, because you get to learn more about how trials run, and then set up your own studies. And that's the way we've done it, and gone from PI to CI. So that's my bit, Jared. Should we talk about from what you would want from me as a PI, as a CI?
Yeah, I think, I've seen you give this talk before. It's such a good talk, and such an inspirational talk about doing research. And one of the things when we started with the Moondance Cancer Initiative, this philanthropic body that has been set up really to try and improve cancer outcomes in Wales, one of the things we decided earlier on, that we weren't going to fund research, and we weren't going to fund the system to do things it should be doing anyway. It was more about pushing the envelope in terms of trying to change the system, testing novel, innovative ideas that actually the system couldn't afford to do, and yet intuitively we knew, or I knew, and the evidence shows that units that are research active get better outcomes. So that's pretty much undeniable, and we knew there were gaps in Wales in terms of where we could be doing more. And part of that, I think, is the classic Welsh thing of like, perhaps we can't really do that here, or perhaps we haven't got the right patients, or perhaps we haven't got the right support. And it's really weird because I never thought I'd be doing what I'm a moderately okay surgeon, but just about everything else I'm pretty rubbish at, and totally disorganised most of the time. But I am quite an enthusiast, and so to be a CI or a PI in a study, you have to have this you have to have curiosity, you have to have a healthy sort of scepticism about some of the things we do, and those trigger questions then. And triggering questions leads to the idea of research, and actually making sure that research is relevant to patients. You find your way through to suddenly volunteering to be a PI or a CI, don't you? And we need CIs and PIs because ultimately somebody has to be sued. And but actually you can't look at it that way. You have to look at it as a way of team building and building things on. I used to work with a anaesthetist. He was a big sailor, and he used to say to me, the two best days of owning a boat are the day you buy it and the day you sell it. And I always try to think about research as a bit like that. There are some amazing days. The day you get that grant, you literally skip down the corridor, don't you? You just think, this is amazing. And the day you get the last patient in, is the overwhelming relief is just incredible that you've actually got to this end. So I suppose, if I was the CI and you were the PI, what would you want from me, I suppose? What do you need from me?
Yeah, so I think you're absolutely right, because as you said, that last day where you recruit that last patient, but ultimately you can't control that, can you? You can create the trial, you get the funding, you set up the infrastructure, but ultimately you need the PIs to do that. And I think as a PI you need a few things. You need recognition, and I think the modern era of social media showing who's recruiting, people like that. So I think you need to give visibility to the PIs and the work they do, because many of the PIs will be doing the work in their extra time, their spare time. Most of us as clinicians, and again that goes back to that document that was sent to NHS England, that there's no time for people to be a PI. So of course the first thing when people come and say, well, I can't do that because I don't have time. So the only thing you can do as a CI is you give that recognition, you highlight what you've done, because I think if you do that, people say, okay, it's not being unrecognised for the amount of work I'm doing. So I think that's probably the single biggest thing you can do. Obviously you design a study that is easy for the CI, and that's be things like the database, how you upload the CI. As soon as you put a complex computer program with multiple passwords that makes it difficult, you'll lose interest. So I think make the trial easy, but more than anything, sort of acknowledge and show people that you have sort of appreciate the amount of work that they go to.
That's really important, isn't it? Because there's two kinds of people, aren't there? There are people that are really clear and are quite happy to say they're too busy. And there's also, that old saying, if you want a job done, get a busy person to do it, because they'll just chuck it on. But they need to feel, and R&D departments within hospitals need to feel there's more in it than just doing somebody else a favour, which I know, ultimately is about doing good for patients, but there has to be rewards and acknowledgement. And I think sometimes the letters that come round that say, look at bronchiolitis that recruited all these patients actually gives them in a sense of kind of pride and everything else, and the CI can really drive that. We did a thing, didn't we, with the heart, where every time somebody somewhere recruited a patient, everybody got an email, which meant, everyone was looking at it, thinking, Birmingham, we're looking at Birmingham, we're going, Chester have recruited again. It's quite sort of slightly embarrassing. Come on, guys, lift your game. So I think you're appealing to that, particularly in surgery, that competitive edge. And so I think we're probably running over time slightly, but whether it's CI or PI, whether you're a research nurse or an R&D director or a trainee, the team thing is really important. And also, the other thing you want from a good CI and a PI, I think, is this ability to say, I don't know, or I don't understand, or let's ask the statistician or the methodologist, or let's, to not understand every bit of the finances, but to know somebody that does, and bring good people in around you is more important than anything else, I think.
And I think the other thing that really good CIs do is investigate meetings. So I know Tom has held really good investigative meetings for Rossini, so you feel part of the trial. So it goes back to that thing, you're not doing someone a favour. You put an investigative meter on, get all the PIs to come along and say, this is where we're at with the trial, thanks very much, and this is what's happening. Because not only do they want to get the acknowledgement for help, but they actually want to know what the answers are and where's the trial up to, and feel part of that. So I think involving your PIs in actually the trial as it progresses is really important.
Thank you.
Thank you.